OCHIN itself also looked forward as we were setting up on our HRs, and one of the biggest things was around research, how to provide qualitative research on the patients' populations that we're serving. So when we look at today, our size of our organization, there's about 2 million visits annually going through the system on patients that are Medicaid, uninsured, are going through specialty programs, Ryan White, homeless shelters. And we also see a lot of churning of patients as they come onto Medicaid or Medicare and then fall off of those programs again. And so one of the things that we did is that we set up a practice-based research network, and this research network has a number of partner organizations, including Kaiser's Center for Health Research, OHSU, Portland State University, and a number of other organizations around the states that we serve. And the goal is to have providers dictate the research they want to participate in. So this is not external agencies that are coming in and saying, we are going to research X. This is the providers actually wanting real-time research that won't take years to come to fruition. We want them to actually provide that research and feedback into the clinic in months, not years. So we got awarded the Extension Center. We won't call that what everybody else is calling it around the country, so we'll call it the Extension Center. The Regional Extension Center for Oregon is providing a number of services that my colleagues here will actually present probably a lot more information on. We provide EHR vendor selection and installation assistance. We provide meaningful use and certification criteria, web-based training, continual education training for providers through webinars and online content. We're providing quality improvement advisors, and actually one of the processes is that each clinic or each organization that signs up with our extension center in the state, we actually will train a member of their staff to become a certified quality improvement advisor. We also provide learning communities through work groups, through online seminars, through in-person seminars around the state. Benchmarking and data warehousing, which is a large part, is to provide a centralized repository data warehouse where all organizations will push their information to us, so we're able to provide qualitative benchmarking between organizations so that one clinic will be able to say, why is this organization providing better diabetic care? Say, I'm doing my diabetic foot exams more frequently, or my retinal eye scans. Why am I performing those underperforming those comparative to other clinics in our region? We also provide HIPAA evaluation and certification. Not necessarily, we're not certifying them as being meeting HIPAA, or what we're doing is basically going in and helping them with the consultative services to make certain that they're covering all of the information they need. Are they performing self-audits? Are they performing evaluations? How are they continuing to do administrative processes and security? And then we also provide consultative services, so network services, billing and payment services. How can we work with their providers in their community? OCHIN's a little different here. OCHIN in the Oregon community has an adoption issue. Our adoption issue is that we're 65% adopted across the state on EHR. So when we look at the adoption of EHRs and the getting to meaningful use, we have a large number of clinics already using EHRs. And our challenge is actually how to go into those organizations and actually give them a reason to join an extension center. And so it's not about the greenfield pasture of actually implementing an EHR and getting an EHR that's meaningful use capable. It's about transforming that current EHR system to meet the requirements. And so part of the issue we're going to face is that when we enter into those clinics, they may actually say, we don't need to do anything, we're going to get to meaningful use. And so one of the processes that we're going to use is an audit, where we will actually go through the criteria list with them, and there will be an audit of their organization that helps them understand where their gaps are. Okay? So OCHIN as a network and a regional extension center said, we have to look inwards and say, let's audit ourselves. Where are we today as far as our membership on EHR when it comes to meaningful use? And so we went through the entire criteria from the final meaningful use regulations and actually did a self-audit against our entire system. And so these are what we're actually seeing today. Of the 25 measures, we have some areas where we are not currently meeting meaningful use. Those have been identified, and there's projects underway or have been underway to actually meet those criteria. Under the CMS reporting, we meet the majority of the requirements for CMS. There's a few modifications to the reports that we need. Under the ability to deliver a care summary, an electronic care summary to a patient on request on a medium that they can take with them, we currently don't have that functionality in place. And so we're going to be implementing that functionality and building out that under an enhancement over the next probably over the next 6 months. We also needed to look at the continual risk, do a risk analysis and security analysis. But that's not a point in a line in the sand where we can say we've met that requirement. That's an ongoing annual requirement. So it's not a, you've met this requirement once. We have to keep these processes going. On drug formulary checks, we basically are currently not doing drug formulary, but the project has been underway for about 4 months to be able to look at that information. And we also have, we found some areas where we were lacking in the ability to deliver patient-specific educational services, resources, so the patient education materials as they left the clinic. And so we've signed a contract with an organization to implement that into the product and integrate it. We also have our patient portal to be able to provide a tethered portal, not a personal health record that's untethered, but a tethered patient portal directly to their clinical record where they can in real time communicate with their providers, look at their lab results, request appointments and medication refills. We also have the information about the registries. So OCHIN currently provides data reports to numerous registries around the country, especially the diabetics registries, the immunization registries, and a number of states' public surveillance databases for the clinical reporting needs for those organizations. And so we do reporting on our members' behalf. They authorize us as an individual organization. So they don't have to pull the data and send the reports in themselves. We will actually do it as a collaborative for them and send the information in centrally to any state that needs that information for their required reporting needs. And we also have built a patient registry system ourselves. One of the goals was to look at how we can provide real-time meaningful data to a provider where they're not having to go into an EHR record and discern what information is necessary for their entire panel. And so we've created panel management and population management tools so our providers can actually sit as a team in a medical home and review an entire panel of patients across their entire community, not only on a clinic-by-clinic or provider-by-provider basis, but across the state and across multiple states. And so the hope there is that it's being used very well in a number of the clinics right now to be able to recall patients that are coming in for depression screenings, that are coming in for diabetic care, and it's working very, very well. So with that, I will hand it back to Michael.
Very good. Thank you, Paul. And just so folks know, we will answer questions. There are a number of questions that are coming in, so we'll answer those after the presentations. Now I'd like to pass the ball over to Walt Culberson and give you a little background about Walt. And he's from Community Health Centers Alliance in Florida. Walt is widely recognized as one of the nation's leading HIPAA privacy and security experts and healthcare technologists. He brings more than 30 years of experience spanning all major facets of the healthcare industry to Health Center Alliance. Walter assumes responsibility for directing the day-to-day operations of CHC Alliance and is charged with helping physicians, nurses, and other health professionals successfully adopt electronic health records and achieve meaningful use of health information technology by 2014. He started his career as a Navy corpsman with a dental technician rating and was a pioneer in the early development of desktop practice management solutions for physicians, dentists, and health clinics. He was the founding executive director of ePrescribe Florida and president of ePrescribe America, a collaborative framework of industry stakeholders working together to help accelerate physician adoption of electronic prescribing by fostering cooperation and coordination among prescribing constituents. He also served as a consultant for e-prescribing, HIT, and health information exchange initiatives in Tennessee, Ohio, and Virginia. Prior to helping launch ePrescribe Florida, Walt held senior executive positions largely focused on the development and deployment of customer-centric business and healthcare solutions. Most recently, he was the founding Chief Technology, Security, and Privacy Officer of Webify Solutions and Availity, an integrated eHealth network started by Blue Cross and Blue Shield of Florida and Humana. He's recognized as a subject matter expert and served as keynote speaker both regionally and nationally. He served as a founding co-chair of CMS-sponsored Southern Insurance Commissioners Task Force and is the founding chair of the Southern HIPAA Administrative Regional Process, SHARP, a public-private collaborative with CMS and HRSA. And with that, I'd like to introduce Walt Culberson.
Why, thank you, Mike, and appreciate that very gracious and lengthy introduction. And I would also this morning like to thank very much the National eHealth Collaborative for the opportunity to be here today, for all those in the audience, and the wonderful thing about the use of technology, which in some cases is what we're all here for, all of those online and nationally listening to this presentation today. I'm happy to share that I went into my role as the program director for the Rural North Florida Regional Extension Center, now the Center for the Advancement of Health IT, which the Community Health Centers Alliance was awarded, wondering why a health center controlled network was given the opportunity. When you think of who we serve, community health centers, and you think of what we're trying to do, technology, those two kind of didn't seem to go together on the same page. I will share with you that some 2 months now into my role, I very clearly see why we were selected, and I kind of had the question why more HCCNs around the nation were not selected. When you think about everything that Paul just said, and really how the HCCNs have been at the forefront of adopting and helping physicians implement technology, it makes perfect sense why we are where we are and why we were selected. So I think, to echo something Mike said earlier, of RECs around the nation reaching out to HCCNs, I think that that is indeed a great opportunity. From the standpoint of Community Health Centers Alliance, we were founded in 1999 as a 501c3 health center controlled network, serving Section 330 safety net health centers and systems throughout Florida. We provide facilities for the selection, implementation, and the support of services that allow our members to expand health care while improving quality. We also provide and leverage resources across the network to enhance patient care while maintaining an independent management structure of those federally qualified health centers that are a part of our network. Our members get to choose from a wide range of services and technologies that they benefit from, and I think that that's one of the keys as you look at how HRSA has basically given out the grants. They've kind of chosen to give them to the health center networks with the opportunity to pull the funding, the resources, and the ability of those health center networks to be able to help the underlying federally qualified health centers with those things they could not either do themselves nor afford, and the adoption and the implementation of technology has certainly been one of those. Today we have 9 members, over 126 physicians represented, and along with over 60 mid-level staff that are using and taking advantage of the services that CHCA provides. As you look at this slide, I think it's really important to note the geographic nature of Community Health Centers Alliance. We very much serve the rural areas of Florida, and that certainly makes us unique. And as we're going to talk later with regard to the coverage area of our particular REC, one of the reasons why CHCA was selected. But again, as you take a look at the opportunity of what we have here, it really is to improve care through reaching out to these communities and these particular members and supporting them in their services, technology, and otherwise.